Lesedi, originally called Lesedi Clinic, was built in 1985. So as clinics, we decided that it's important to change the facility as time has gone by. We've invested quite a bit of financial capital into improving the services that we provide in Soweto. That would be renovating the entire facility. We've recently just opened up our new labor ward, and we've been doing so over the past few years. So we're still seeking to ensure that we create the best kind of facilities for our people within the communities. You know, these facilities were built by the community, for the community, so we'll continuously help to grow and improve.
So we've recently opened our new labor ward, which is now bigger and better, state-of-the-art equipment. The new things that we've included there is the water bath. You know, for women who'd like, you know, water is used also as a form of pain management in labor. So if a woman has a preference, this is a new thing that has been put in our ward, then the woman is given that option to deliver there. We've got new beds that are state-of-the-art when the doctors are delivering their patients without any difficulties. In our new maternity ward, we've included a new nursery, which is much bigger, which has more better equipment, cardiac monitoring of the baby, so that we don't miss any abnormalities on the new baby, because anything can happen. Baby can come, you think the baby is well, can't you? If you don't have the proper cardiac monitors to monitor these babies, you can miss something. And also, you know, we've got neonatologists who works hand in hand with us to manage these precious babies. So those are the things that we've included, and they are working perfectly.
Good evening, colleagues, and welcome to our weekly webinars hosted by Phoenix Health Group. We're excited to have you here once more to this webinars that we've been hosting for the last few years. And every week we are delighted to see most of you joining in as we present you different speakers with different topics, covering a wide variety of topics from the medical disciplines brought to you by experienced clinicians and academics in their own fields. And so tonight we're also delighted to be doing the same thing, bring you information from one of our esteemed colleagues who's working with us in our emergency departments. And please know that these meetings webinars are CPD accredited. And so when you join in, you should provide us with your details for registration with the HPCSA or the health profession, the nursing council or the pharmacy council, or any of the other health professions councils that are regulating people who are joining us. And so that we'll be able to send you the CPD certificates that we upload and send to the HPCSA for the points to be allocated to you. So please make sure that you provide us with your correct email address, correct cell phone number, and correct details so that the allocations can be made. And lastly, please note that these webinars are streamed live on YouTube. So at any time when you wish to go back and check these webinars, you are free to do so. And most of the questions we're being asked is whether the presentations will be given after this, but it all depends on the speakers. And normally they prefer that they be sent out in PDF files if they do so, because it's the information that they've worked hard on. So this evening, we're excited to be presenting to you Dr. Kelly Jacobs, who's an emergency physician, who's stationed primarily at Tambo Memorial Hospital as a specialist emergency physician. has been working there for some time and is also an associate lecturer at the University of the Witwatersrand in the Division of Emergency Medicine. She was awarded the Resuscitation Council of Southern Africa Medal for the best candidate in the practical component in college examinations for Part 2. And Dr. Jacobs has presented research at the African Conference on Emergency Medicine in Ghana, and working in a busy unit at the hospital where she is. She has gained a wealth of experience over a variety of patient presentations and palliative care medicine emergencies. And a special interest is actually in palliative care and critical care in the emergency department setting, and is set to start a fellowship in critical care later on. So it's getting more qualifications. So Dr. Kelly Jacobs will be talking to us this evening on the role of the emergency medicine physician in organ donation. Quite an interesting topic, ethical discussion that most of us need to be aware of. And we're excited, Dr. Jacobs, that you are here to share your knowledge and experience and expertise on this important subject. Thank you very much, and welcome to Clinics Health Group webinars.
Thank you, Dr. Bila, for that warm welcome, and to everyone online. I'm just going to share my screen and then we'll get started, if that's okay. Okay, if I can just get a confirmation that it's still in the proper format before I start.
Yeah, it's
Yes,
fine.
yes, Doc, thank you.
Perfect, thank you. Okay, so just off from that introduction, my name is Kelly Jacobs. I'm a specialist emergency medicine physician based primarily at Tambo Memorial Hospital. And I'm going to give a talk today that I've given once before in another platform. And it's a topic that's close to my heart and that I'm passionate about. And that is the role of the emergency medicine physician in organ donation, and a tale of the different hats we wear. And I'm well aware that many of you may not be emergency medicine physicians or may not be working in EDs, but I think this talk will still have valuable insights that you can take with you into whatever department you're working in. And I hope you enjoy the presentation. Just before we get started, a special thanks must go to the South African Transplant Coordinator Society, and specifically Ms. Anya Meyer, for the guidance on this topic and the use of the organ donation and tissue reference file, which is also called the RED file. And I've used many of the infographics directly from this file in the talk. The RED file was created as a guide for medical professionals in hospitals, and its aim is to inform, educate, and to supply quick reference information for anyone in the scenario of having a potential organ donor. These files are usually located in ICUs and in emergency departments, and I would suggest if you've never seen this file to go and look to see if you have one, and if you don't have one, if you don't have one, to try and get one for your unit, as they're a vital resource. You can contact the South African Transplant Coordinator Society and they can help you to get one. Many of you may believe that you know everything there is to know about organ donation and the process of it, but I believe repetition is always helpful, and this will allow for a smoother process for the next time you are confronted with a potential donor. Before I get into the different roles we play, I just want to give some information as to why this topic is so important. Here are the statistics on the transplants from 2021 that are published on the Organ Donation Foundation website. Now, these numbers may seem impressive, and to each of these individuals, these organs were life-saving. But it's important to note that for the same period, there were close to 5,000 South Africans on the waiting list for donors. And this equates to only about 4% of those requiring them receiving the organs that they need. One donor can offer 7 or more life-saving organs, but it is also extremely important to note that through tissue donation, many lives can be improved. Early donor identification and optimal donor management is crucial for successful organ procurement and donation. Heart, lung, liver, kidney, and pancreas donation is done at various designated hospitals in South Africa, and organs are allocated according to a national transplant waiting list. We often tend to focus primarily on organ donation, but as I impressed in the previous slide, tissue donation mustn't be overlooked. Tissue donation refers to tissues like bone, ligaments, tendons, skin, heart valves, corneas, and scleral tissue. Certain living and deceased individuals can be tissue donors, and unlike organs, tissue doesn't need to be recovered immediately, although early referral to your local transplant coordinator is useful to help make a smoother process. As emergency medicine providers, we really can make a difference. The first study shown here was published in 2009 in Academic Emergency Medicine, and they collected data from all solid organ donor referrals made to a single organ donor procurement organization serving 78 hospitals over various states in the United States over a 45-month period. It showed that if potential donors were referred from the emergency department versus inpatient wards, they were more likely to go on to become successful donors. Even after controlling for confounders, referrals from the ED were still statistically significantly more associated with successful donation. Some of the theories for this are that in the emergency department, we come across the classic donor, for example, someone with a catastrophic head injury. Secondly, that inpatients can have a longer stay and therefore organ dysfunction. And thirdly, that it allowed for early counseling of the family by the organ procurement teams. The second article, also out of the USA, was published in 2014, and it also showed once again that referrals from the ED were more likely to go on to become organ donors than referrals from the ICU. So it really just impresses that early referral can really make a difference. Now it's time to discuss some of the roles we play and the different hats that we wear. First and foremost, we are clinicians. This is the hat you are most comfortable with, the hat you wear every day, and the hat you could even wear in your sleep. As the patient's primary treating physician, you tried your best, you worked hard, and you treated your patient with the best intention. No one starts treating their patient with the primary focus being organ donation, but as your treatment journey may go on, your patient's prognosis may become poor, and this could become an option. Our second hat we wear is that of the investigator, to be the detective. When we're in this role, we're trying to identify potential organ donors in our units. And it is very important that all medical, nursing, and allied healthcare staff should be familiar with the identification and referral process for organ donation specific to your unit or hospital. It is the shared responsibility of the entire team to help identify these individuals. It is also important to note that when trying to identify a potential organ donor, there is no age restriction. And thirdly, to address the scarcity of organs available for transplant, certain extended criteria may be applied and include specific comorbid diseases. In any case of a specific donor or a potential donor, rather call your local transplant coordinator to assist you with this decision. They will make an assessment and determine suitability of the proposed donor. When identifying tissue donors, in most cases, tissue donation can occur irrespective of the cause of death. Some specific donor characteristics to consider include for corneal donation, which can take place up to 24 hours after death, although the earlier the better. Donation can come from healthy individuals between the ages of 6 and 65, or in some cases, even up to the ages of 70. Please note that cataracts and poor eyesight are not a contraindication to referral, but patients who have had previous laser eye surgery, glaucoma, keratoconus, certain infections like TB or HIV, and certain malignancies like lymphoma or leukemia are excluded from potential donation. Skin can be harvested up to 48 hours after death, and bone, ligaments, and tendons up to 5 days. These can be donated by healthy individuals between the ages of 16 and 80 years who do not have any malignancies, infectious diseases like hepatitis B, C, syphilis, or HIV, or who died from septicemia. And finally, Heart valve donation, which can take place up to 36 hours after death, can be considered in deceased individuals from the ages of 6 months up to including 55 years. Some exclusion criteria are if the cause of death was unknown or due to sepsis, cancer, toxin ingestion, bloodborne infections, or trauma to the heart. But almost anyone can be a tissue donor, so please make those referrals. The third hat we get to wear is that of the superhero's tiara. Let it resonate with you that every donation starts with a referral. So please make that call and be the superhero. It is best practice for the transplant team to assess a potential donor before death, as this allows for the end-of-life discussions to be fully informed. The only way this can happen is through early referral. There is no legal requirement to make a potential referral, but the actual donation of organ and tissue is closely regulated by South African law. Here are the suggested clinical triggers for when you should contact your local transplant coordinator to review a patient for a potential organ donation. When the decision is made to perform brainstem testing, in patients with catastrophic brain injuries who have a GCS of 4 or less, not explained by any sedation, or whether there's a decision made to withdraw organ support and death is expected. The main legal requirements for organ donation after brain death include the certification of brain death, consent from the appropriate next of kin, in cases of unnatural death, consent from the state pathologist, and finally, consent from the superintendent or medical manager where the donation is to be performed. As emergency medicine providers or even primary treatment physicians, our key responsibility lies with the certification of brain death. The other facets that are required, your local transplant coordinator will assist with. In some centers in South Africa, there may be consideration for donation after circulatory death. This is not available in all centers, and rather talk to your transplant coordinator if your patient does not meet the criteria for brain death, as they could still be a potential donor. Donation after circulatory death can occur in a palliative care setting where there is planned withdrawal of non-beneficial treatment and imminent death is expected. You need to refer to your transplant coordinator early before this palliative care process or extubation occurs, so that the appropriate consents can occur. So should the patient arrest within a defined period, donation can then take place. The determination of brain death is a separate lecture all by itself, and I won't be touching on it in detail. But please note that before commencing brainstem testing, please ensure that the cause of death or the likely cause of death is known. Please make sure that the effects of CNS depressant drugs or muscle relaxants are no longer in the system. And this can be by ensuring that you're testing more than 6 hours after the last bolus of these medications, or more than 12 hours after an infusion has been stopped. Your patient needs to be normothermic with a systolic blood pressure of more than 100, with normal HGTs or glucose levels and normal sodium ranges and a fairly normal blood gas. This testing needs to be performed by 2 registered medical doctors who are not part of the transplant team. One of the doctors must be registered with the HPCSA for at least 5 years, and the second doctor cannot be an intern. You can follow the QR code shown to take you to this article on the South African guidelines on the determination of death. This article provides all the information that you'll need, prerequisites to testing, how to perform the test, and how to interpret the results. And I urge you all to read it and to keep it on hand for when you will need it. Alternatively, the red file, which you can place in your units, has helpful infographics on how to perform these tests and how to interpret the results. As this talk is based in Gauteng, I've included the contacts for the organ donation coordinators across our province. For other provinces, you will need to reference the red files in your various units. Also included in your file should be the cell phone number of the coordinator specifically linked to your hospital. If you don't have a specific coordinator in your hospital, the number supplied here for the Gauteng Province Solid Organ Transplant Division can be used, and they will take your call and advise you on who you can talk to or whether you can just make the discussion with them. These are the same numbers for Gauteng and some other provinces for tissue donation, but it's not an exhaustive list. And I refer you once again to the red file for all the rest of the numbers for tissue donation. The fourth hat we wear is the hardest role we play as primary treating physicians, and that is counseling families on bad news. This role is not unique to patients that may be potential organ donors, and this is something that we do daily. I personally know that I have these types of conversations multiple times in a week. I often think that we are the people that the families see on the worst day of their life. And if there's anything we can do to make this process any simpler or any better, we need to strive for that. And through compassionate and empathetic counseling, we may be able to achieve this. It is vital to note that the organ donation cannot take place without consent. An appropriate breaking of bad news can help your transplant coordinator to get that consent. A helpful resource that you can read regarding family counseling is the BITS Transplant Procurement Handbook, created to increase the referrals to our procurement coordinators and then increase the conversion of these referrals into successful donations. This handbook is aimed mainly at individuals that are involved in the organ procurement process, but it has many helpful insights. Most countries, including South Africa, advocate for a decoupled approach when talking to patients. Breaking bad news by the primary treatment team on the one hand, and then the introduction to the concept of organ donation on the other hand, usually by a separate team via your transplant coordinator. As the primary treating physician, it is our responsibility to counsel the family regarding the diagnosis and prognosis of their loved one in a compassionate and empathetic way. Above is their suggested process on family counseling, and our involvement is mainly in the first 3 steps: planning the approach, breaking the bad news, allowing for a moment of reflection, and then introducing your transplant coordinator in a sensitive way. Planning the counseling session plays a crucial role in ensuring a successful, respectful, and sincere session. Part of the planning includes the presence of the appropriate family members and team members. Team members should include senior doctors and nursing staff comfortable with counseling of this nature, who preferably understand and know this patient's case. If there have been repeated interactions, this should preferably be the same treatment team that is talking to the family. And if possible, doctors from all teams involved, so for example, both the emergency department and surgery, should be present. Consider early on whether if you will require an interpreter, and please find an appropriate person to play this role. Ensure that the entire family that needs to be there is present. Choose an appropriate time for this counseling to take place, a time when most of your treatment team and family can be available without making too much of a delay. Find an appropriate place for this conversation, somewhere private and quiet where you won't be interrupted, that has seating for everyone. Please know the names and titles of everyone in your team, the patient, and if possible, the family members that you're going to counsel before walking into this session. You need to prepare yourself emotionally to lead this session, and this will help ensure a respectful and professional yet empathetic interaction. Above, you can see the checklist included in the handbook that you can choose to use as part of your preparation to a session like this. Actually breaking the bad news is never easy, no matter how well you've planned or how many times you've done this before. The aim of this conversation is to convey the message that brain death is death. To begin, it's always best to assess understanding so that misinterpretations can be corrected. Even though the families may have been counseled on multiple times before, it doesn't mean they always remember or interpret the information as you might think. Provide a summary of the patient from their time of their arrival and throughout their admission. It may be useful to use visual aids like the CT scans to provide further information, but please try and avoid medical jargon. You then need to provide the family with a so-called warning shot statement. An example of this would be to say something like, "Unfortunately, I have some bad news to tell you." Then it is time to break the bad news, to convey the diagnosis of brain death. Don't mince your words and convey the diagnosis correctly. We have performed the brain function testing on your family member, and there is no brain function. I am so sorry to tell you that your family member is brain dead. As you can see in the example, you can then follow this statement up with something like, "This doesn't mean that they are going to die or that they might die. This means that they are already dead. I am so sorry for your loss." It is crucial to avoid phrases like life support or to help correct misconceptions early on. Rather say that the machines are supporting their loved one's organs, but always emphasize that brain death is death. Some families might find it helpful to observe brainstem testing to give them closure, but this is not the case for everyone. Then allow for a moment of silence. Allow for reflection and for this information to sink in. Allow for questions, clear up any misunderstandings, or repeat the information as much as required. Then it's time to give the family some privacy and a chance to visit their loved one before you continue. The example shown here of breaking bad news is included in the Facts Handbook, and it's adapted from the National Health Services Blood and Transplant Group strategy for approaching the families of potential organ donors, and it includes the principles we've spoken about. You then need to introduce your transplant coordinator. Try to avoid the title transplant coordinator or transplant coordinating team, and rather introduce them by name. The family may not yet be ready for the introduction to the concept of organ donation, and allow the specific coordinator to continue the counseling and to bring up the subject in a sensitive manner. Finally, the last role you need to play is that of the intensivist. You need to respect the donor and their family's wishes by making sure the organs that are being gifted to someone else are closely monitored and optimally cared for. The best place to preserve these organs prior to transplant is within a well-functioning body. Once again, optimal donor management can be a talk all by itself, but I've included this infographic from the RED file that summarizes the pertinent goals that need to be achieved, which includes adequate ventilation and oxygenation, maintaining normal blood gas parameters, aggressively managing perfusion through appropriate fluid management and use of inotropes to get a systolic BP of more than 100, correction of any electrolyte abnormalities, maintaining a normal urine output, and to be on the lookout and be able to treat common donor complications like diabetes insipidus. The RED file has detailed guidelines on how to optimally manage all organ systems, but when in doubt, pick up the phone and talk to your transplant coordinator to ask them for help. In summary, this talk has covered a wide range of roles that not only the emergency medicine physician, but anyone involved in patient treatment can take points from. There's been a lot of information given, but if I had to impress any single point, it would be this. Every donation starts with a phone call, so please pick up that phone. Thank you so much.
Oh, thank you very much, Dr. Jacobs, for the frank discussion on how to handle this very difficult subject. I'm sure most of our colleagues do not want to see themselves in that situation when they've got to break the news. But I think after tonight's presentation, it gives most of us the comfort that we've been given the tools of how to deal with this subject that is both painful for the families and for the practitioners. I mean, the nurses and the doctors and everyone else who's involved in this case. Yeah, I've seen one of your colleagues has joined us that you mentioned in your presentation. She's part of this discussion. But I'll open this platform for questions now, colleagues. It was quite short, but to the point and very helpful. I think maybe one of the questions that I would ask, maybe just general, whether I've been trying to, you were showing this codes that you can scan, and I found that was so easy. I was able to scan the codes and get the documents as you're doing the presentations. But if anyone wants to have access to the presentation, I know it's quite brief, are you able to share with the colleagues this presentation? Yeah, you're muted. You're muted, Doc.
Yes, thanks. Sorry, I didn't have permission to unmute.
Okay.
Yes, for sure. I'm happy to share my presentation in PDF format. But I can definitely say that the South African Transplant Coordinator Society has really great websites available that can also provide more information. But I'm happy to share my presentation if people want to reference it as well.
Okay. Yeah, there's a question, is this an ethics or clinical general CPD point? I think this is an ethics presentation, so you should be getting ethics points for this.
Yeah.
Yeah, so that's it. Yeah. Okay, in your experience, because you've got experience both the public and the private sectors. Have you noticed any differences in terms of the doctors working at both sectors being quite keen or hesitant to get involved in approaching the families for organ donation? Which one? Are there similarities or are there differences?
I think it's difficult for me to compare exactly. I've been involved in multiple potential donors and in successful donors in the state sector, but in the private sector, I've never personally had a patient that was an appropriate candidate for referral. And I think maybe some possible differences could be often in the private sector, patients often get into ICUs or high care settings a lot quicker than in our state facilities. So our emergency medicine physicians may be taking on this role due to the patient staying in the emergency department for longer, whether in a lot of your private facilities, these patients may be taken quite quickly to ICU, and therefore this process will be happening more as your inpatient. And I think whether doctors are hesitant or not to be part of this process is not always a state versus private conversation, but also a personal conversation, whether you've been exposed to this kind of discussion before or whether you've had experience in it. But like I said in my talk, there's no legal requirements to refer a patient. And there's no harm in having a discussion with a transplant coordinator if you are in doubt or you have any discomfort or there's any questions you need answered. They are more than willing to have conversations with you to help in any situation.
Yeah, thank you for that response. One of the participants wants to know, how long do you keep a patient on the life support machine while brain dead?
So just before I answer that question, just to make a clarification, like I said, you shouldn't be referring this to life support machines. There may be ventilators, there may be infusion pumps, there may be various monitoring devices. But when you're talking with the patient and their family, more the family, you shouldn't be referring to these devices as life support devices. Rather, organ support or just name them by their names, like ventilation. And then the question was, how long do patients need to be on these devices before making that decision? Am I correct, Dr. Bila? Sorry, I just forgot the finites of that question.
That is, for how long should you keep the patient on?
Perfect.
In the machine.
Yeah. So to make the determinations of brain death, like I said, there's that helpful infographic that you could have followed that would explain everything. But like I said, you need to make sure that you know what the cause of death is and that there's no confounders that could be making your brainstem testing come out as a false positive or false negative. So that's ensuring that your patient's not on any sedative medications and that they are stable. If the family are needing time, or they may not yet be accepting of this diagnosis, general recommendations is that patients can be kept on ventilation while the patient's families are deliberating. And a lot of the articles reference about a 24-hour period before then removing that patient from the ventilator, as once patient is defined brain death, they are certified as death. So brain death is a certifiable state of death. And this may allow the family some time to acclimatize or to go through the separate counseling they need. But I think, like anything in South Africa, these decisions are also based on distributive justice and the kind of needs and pressures that you could be facing in your department. So it's difficult to give you a specific time frame that you need to, that you would need to have.
I think there's a follow-up question, of the question similar to that. This colleague says she's seen 3 patients who have declared brain dead, but the physician was a bit hesitant to make the call. How much time do they have to make that call or to approach the families? You know, when you know that this patient is actually brain dead, whether you've done the test or or not, or but that you need to start that conversation. How much time do you need before you can engage the families in that conversation?
Yeah, so look, once again, I don't think there's a specific time frame I can give you, but like we spoke about during the planning of the session, you need to find an appropriate time to have this discussion. And if you've made this diagnosis at 2 a.m., that might not be the appropriate time to bring in family members and have a full meeting with all family and staff that are available. So I'd suggest that, firstly, if you are uncomfortable with making that diagnosis of brain death, that you then find a colleague that's of the appropriate qualifications that can help you. And then even in a lot of your private sectors, you have trauma counselors that can join you during your counseling sessions to help you with this. But once you make the diagnosis, you do need to document your findings, but there's no specific time that you have to call the family in for. Again, I would just make sure that it's an appropriate planned session. I wouldn't rush and have an unplanned session that you're not ready emotionally or, clinically to have with a family if it's not the right time.
Yeah, these difficult conversations. There's a question here, is that how does one interact with the funders? I think now you said you don't have much experience with medical aid or the private sector, but maybe if you can just, or maybe Anya is here, maybe she has had.
So I can answer this question, but Anya can also welcome to jump in at any time.
Okay, all right.
Once a family has agreed to organ donation, there is no charge for further care for this patient or for the procurement situation. So there is no cost to the patient or family through the process of organ donation.
I think that's very clear. Now the question is, who switches off the ventilator after brain death?
So palliation of patients is also a very large topic to get through tonight. But this needs to be, obviously, especially in private, you're usually working as a treatment team. And I think it's important that before you take any steps like this to palliate your patient, that you make sure all members of the team are informed of the decision and everyone is happy to proceed. That includes your senior nursing staff as well. And it's also important for practitioners, and we've recently had new HBCSA guidelines on withdrawing and withholding care. And doctors are well within their rights to withdraw care that is deemed futile to the patient. And once you've made that diagnosis of brain death, that patient is certified as dead and ventilation is no longer beneficial for that patient. So there is no legal repercussions that can happen to you by removing that patient off the ventilator and doing the palliation. I would warn against doing this if the family have not yet come to terms with what is happening and that you may need ongoing counseling before they're ready. But often it's a matter of placing a T-piece oxygen, even though you know the patient is not going to draw a breath because you've confirmed there's no brain stem reflexes, and allowing them to die. But that's in the situation if the patient has then refused organ donation. If this patient is going to go on to become an organ donor, that will be taken away from you, that responsibility. This patient will then be transferred to a facility where the donation will take place and the harvesting of the organs, and then the patient's final resting place will usually be in theater. So the only time where you will be switching off the ventilator is in a patient that has refused organ donation, but you've made the diagnosis of brainstem death and you need to perform the appropriate palliation. For a donor that's going on for donation and harvesting, that's not your responsibility, and the transplant team will take over.
Okay, thanks for that, sir. Now, in the case of a patient who is in ICU and then declared brain dead, does physio continue? I think it's part of idea. Does physio continue? I think one of the physiotherapists has to know. With suctioning and passive movements of the patient.
So you still need to do good suctioning and ventilation management of these patients. Obviously, mobilization may not be as important as the treatment goal, but definitely chest physio could be considered to make sure that we have, as I showed you on those treatment goals, adequate oxygenation and ventilation of the patient. But usually once these patients are going to be defined as donors, they will be transferred to facilities where the harvesting will take place. And I mentioned if there's any confusion as to what treatments you should continue or stop, the transplant coordinators by this stage should be at your facility and working hand in hand with you to manage this patient.
Okay. This one is a bit long, it's a quite long question, but also complicated. Since in your experience, over and above the biochemical, serological, hematological findings, is there any immediate role of imaging in the selection of your donors and or respective organs in question? And how often do you request imaging post-mortem for the purposes of organ donation?
So obviously, we're looking at two roles here. Whether you're doing imaging while you're working up your patient, so that is different. That's part of your treatment plan. You had a patient with a hemorrhagic CVA or maybe a trauma, and you did imaging to confirm their diagnosis. That is a separate case. You do not have to do imaging to confirm brainstem death. An EEG is not particularly sensitive. You could consider things like MRI, angiography, and flow perfusion studies, but these are not required in the diagnosis of brain death. That is a clinical diagnosis. And you would only be advised to do these kind of tests by your transplant coordinator if there was any reason that you couldn't perform some of the brainstem testing as set out in the guidelines or the red file that you're using. So to answer that question, no, there is no direct imaging that you need to do to confirm brain death in these patients.
Okay. Next question is going back to brain stem testing. How reliable is the brain stem test, and how do you avoid wrong certification?
So I would suggest you definitely need to read that article that I posted the link to. It provides you, so that article was written by a lot of experts and it's evidence-based, and it details everything regarding to certifying death in a patient. And the main thing when you're doing brainstem testing to avoid any false results is to make sure that the prerequisites are in place. So prerequisites in terms of when your last sedation was given, what's your patient's glucose and sodium level, what's their blood gas looking like, and what is their temperature and blood pressure. And once you fulfill those requirements for each individual brainstem test that you're doing, there are prerequisites to make sure you're not getting falsified results. And that article clearly details all the things you need to do before each step, how to do this, how to do the test, and then how to interpret the results. And these results, it's a clinical testing that needs to be done. And like I said, it is a legal definition of brain death. It's performed with appropriate prerequisites in mind.
Okay, thank you very much. It has been a engaging discussion. Colleagues, anyone else who still has a question to ask, if you can just, if you have, you may just maybe raise your hand and then we'll recognize you. Otherwise, I'm going to ask in the meantime if Anya is still here. Any comments you want to make towards closure? I'm sure most of you don't know. There's a comment here, informative talk. We need this awareness also to
Dr. Villa.
Oh yes, yeah, we'll come back here.
Yes,
Go ahead,
good evening, everyone. Yes, thank you very much for this opportunity. I just want to say well done, Doctor. It was an excellent presentation. As a coordinator, it's always nice to sit and listen to other presentations. So well done. You have made us proud tonight. Answered all the questions exactly the way it is. And we cannot work without the ED team and the ICU team. I absolutely agree. In the public sector, most of our donors comes from ED because they don't really get to ICU, and your presentation was spot on. As coordinators, we're always there to support, and mostly we start the process once we are called in and we get the consent, etc., like you've mentioned. So yes, well done. Please do refer to us. Our numbers are there. You're welcome to phone me at any time. I will get you in contact. If it's not me, I'll get you in contact with the right coordinator in your region, and let us save lives. I just want to add on to a little bit of positivity. Last week, we had 3 donors. We transplanted quite a few patients. One donor was actually from the ED department in Charlotte Macleod, Johannesburg Academic Hospital. We transplanted 4 patients from there, and currently we are again busy in a ED department with a consented donor, and we could not have done this without that first call. And I'm very, very proud of our ED doctors and ED nurses. Thank you very much for your support.
Thanks a lot, Anya. Just for clarity, when we speak of ED, we not only talk about the emergency physicians, we also including the trauma surgeons.
For sure. Like I said, anyone that's involved in treating of a patient can make these calls, can make these diagnoses. If you are called to assess a patient as a surgeon or as an internal medicine physician in the emergency department, you can make these assessments and referral from the ED or from your ward or ICU, wherever you find yourself in.
Yeah, no, thanks for that. There's a question here also. It says, are brain death patients being fed? Their digestive system is working well?
So once you've made the diagnosis of brainstem death, you won't be feeding these patients. You'll be doing adequate fluid management. These patients can have often quite complex electrolytes and fluid shifts. So you're mainly managing them through intravenous fluid regimens.
Okay, no, thank you very much. It has been an excellent presentation and quite short, but to the point, and I think it provoked a lot of conversations and discussions. There's a last comment here, gratitude. Well, I'm going to ask you to unmute yourself. Professor Makunya, it's good that you maybe just unmute yourself and make this comment and do the closing remarks for us if it's possible. Prof?
Oh, okay. No, thank you very much. I'd written there that gratitude to you, Dr. Jacobs, for an enlightening presentation. Skillfully, you've explained the delicate task of delivering challenging news to families without diluting its essence. It's quite important. I really appreciate that about your talk. And of course, afterwards, having to introduce the discussion on organ donation. Thank you very much. Really appreciate it. Thank you.
Thank you. Thank you for your kind words.
Thanks, Professor Makunyan. Professor Makunyan is the head of ophthalmology at Steve Biko Academic Hospital and also at Pretoria University, and also a member of our risk committee. So quite appropriate that she made that comment in the closing remarks.
Thank you.
Oh, somebody still wants to ask questions. I thought we'd done. I would like to understand the process of harvesting the organs. Is it done in theater, and where and how are the organs kept while waiting for the transplant?
I think Anya would be the best person to answer this question. So if she can unmute herself.
Okay, Anya, please go
Uh,
ahead.
Thank you very much for the question, Dr. Bila. Thank you, Dr. Jacobs. Yes, so it's a very dignified process. First of all, we will do a donor pause in the unit, either ED or ICU. We will do a donor pause, meaning that is a respectful way of saying thank you to the donor and the family. We will do a guard of honor, and then in the guard of honor, all the nurses and doctors will actually stand as a guard, and we will push the patient into theater. This is a very, very honorable and respectful procedure. When we get to theater, once again, there's a very big team together because we've got an abdominal team and a cardiothoracic team, depending on how many organs are going to be procured and how many organs have been consented for. And then we will start a dignified process again. There's a scrub sister who will do the necessary preparations prior to surgery. And once again, we will do a donor pause. This donor pause is once again just done to respect the donor for the gift of life, and also just for everybody just to be centered and, to be how can I put, again, aware, why are we doing this? And then the surgery will start. We've got two phases. There's a warm phase and a cold phase. The whole procedure the warm phase takes about an hour and a half, and then the cold phase will follow depending on the size of the donor and also again how many organs we are procuring, maybe another hour and a half. The sequence of organs to be procured is heart is first because the cold ischemic time is 4 to 5 hours, lungs 6 hours, then the liver 8 hours, and kidneys are the most kindest to us all, and that's 24 hours. But of course, the quicker we can transplant, the better, to get perfusion and oxygenation back for the new recipient. And that's a very dignified process. After all the organs has been procured, the body will then be clean. The incision lines will be closed with stitches, covered with dressing. The body will be washed by us as coordinators, will be put into the body bag, and respectfully then will be going down to the mortuary. If it's an unnatural cause of death, the state pathologist will be involved. The body will go for post-mortem. If it's a natural cause of death, then the body will be then just collected by the undertakers from the family. I hope that answers the question.
No, it does. It does. I think for most of us, I've heard a lot about organ donation, but I mean, the process has been so well explained. I think the first time that I hear it being so well explained, and it is quite a dignified process and a somber moment also from what you're saying. This should be the last question, Dr. Jacobs, from Felix Masio. Euthanasia versus brain death, your view?
So euthanasia is a completely different topic, and it is not currently legal in South Africa. And I think that's a whole separate kind of lecture that we can have. But I think I don't want to muddy the waters or make any confusion, but brain death and donation after brain death is got nothing to do with euthanasia, and I think that would be a topic for a different lecture.
For the date with you. So we'll call you back to come and discuss euthanasia then. Thank you very much, Dr. Jacobs. It has been a wonderful time that we've had with you, and quite a 30-minute presentation followed by a similarly intense discussion on the presentation. Quite helpful. We just want to thank you on behalf of Clinics Health Group for making your time and availing yourself to be here with us, and also to say thanks to Dr. Samir Karim for making you have contact with us so that at least you can come and share your thoughts, your experience, your knowledge about this important subject. And just want to thank all the colleagues who've joined us this evening for being here week in and week out. We average about 400 these days with participants coming into this presentations. And thank you for very much. And we hope to see you again next week. We'll be having a discussion with Prof. Court on laparoscopic surgery next week, and we hope that you'll join us. I want to say thanks to Carmen Anza and Stoko from the marketing team for working with us and preparing the logistics and for these presentations. Thank you very much, colleagues, and good night.